Okay, guys, good morning, everyone. Today we are going to continue with the book club. Today's chapter on the cardiac anatomy, physiology, and imaging modalities with your colleagues, Dr. Rehan. She may start.
Good morning, dear colleagues and teachers. My topic is about cardiac anatomy, physiology, and imaging modality. First, start with anatomy. First, we have frontal projection. The right border of the cardiac silhouette is formed primarily by right atrium, with superior vena cava entering superiorly and inferior vena cava inferiorly. The left half border is created primarily by left ventricle, left atrial appendage, pulmonary artery, aortopulmonary window, and aortic knob extend superiorly. On lateral projection, the right ventricle border forming anterior adjacent to the sternum. The left atrium is border forming in the high posterior subcarinal region. Left ventricle forming inferiorly and posteriorly. Right atrium is divided into two portions, smooth posterior wall and trabeculated anterior wall. The right atrial appendage extends superiorly and medially from superior vena cava opening. We have crista terminalis, which is a muscular ridge that runs from mouth of superior vena cava and fades inferior to mouth of inferior vena cava. In the posterior wall, we have superior vena cava with free opening and fossa ovale. Also, we have inferior vena cava that have valve called Eustachian valve, and medial and anterior to this inferior vena cava, we have coronary sinus and this valve, which is called Thebesian valve. Right ventricle is divided into posterior or inferior portion, which is heavily trabeculated, and less trabeculated anterior or superior portion. The two portions are divided by crista superventricularis, which is muscular ridge with a septal band called moderate band, which is present in 40% of the patient. That's connect interventricular receptor to papillary muscle. And the more cephalate portion of right ventricle is called conus arteriosus. That's lead to pulmonary trunk. About pulmonary artery, the left pulmonary artery extends posterior as a continuation of main pulmonary artery, coursing over the top of left main stem bronchus, then descending posteriorly. Right pulmonary artery extends horizontal to right, bifurcate within pericardial sac, and exists the right hilum as the truncus anterior and interlobar arteries. The left main stem bronchus is hypoarterial, while the right one is epiarterial. Left atrium is the highest and most posterior chamber. Its smooth walls are nestled between right and left bronchi, and this posterior wall abuts anterior wall of esophagus. Also has left atrial appendage, which extends superiorly, and it is smoother and larger than right atrial appendage. And on inferior border of left atrial body, we have mitral valve. Left ventricle. The mitral valve is the conduit of blood flow from left atrium to left ventricle, and it is high posterior valve plane of left ventricle. There is mitral valve, which have anterior cusp large, and it's near the interventricular septum, while posterior cusp, which is smaller and located posteriorly. And we have chorda tendineae that's connect mitral valve leaflets to papillary muscle. The inflow of left ventricle is posterior to mitral valve, while outflow is anterior. About cardiac catheterization. Left side catheterization is normally accomplished by arterial puncture in femoral or branchial artery. It's typically used for arteriography, coronary and coronary bypass graft angiography, ventriculography, and evaluation of patent ductus arteriosus. Here we have a catheter in ascending aorta, and we can see also contrast in left ventricle due to aortic valve insufficiency. Right side catheterization is typically accomplished by venous puncture in femoral or brachiocephalic vein. It's used for pulmonary angiography, catheterization of right atrium and right ventricle, or evaluation of shunt lesion. Here we can see pulmonary arteries, and we have here AV malformation feeding by large artery. This is normal value of cardiac catheterization. Each ventricle has its own pressure and oxygen saturation. About the chest radiography, first the cardiac sulfate. About size, the cardiothoracic ratio should not exceed 0.5 in erect PA radiograph or 0.6 on a portable or AP examination. Other factors should be considered, such as fat mass and pectus deformity. About shape, various contour effects can clue to underlying disease. First, you have a water bottle configuration with which occur with pericardial effusion or generalized cardiomyopathy. Left ventricular or Schmo configuration describe lengthening, rounding of left heart border with downward extension of apex resulting from left ventricular enlargement. Right ventricular hypertrophy and enlargement tends to lift the apex and create more horizontal vector to cardiac axis. As we know, each ventricular hypertrophy causes little enlargement unless it's associated with dilatation. Moguls of the heart. Skying the moguls of the heart refers to the left mediastinal outline beginning at the aortic knob.
What does it mean moguls? Did you look? What does it mean moguls? What معنى شنو كلمة moguls؟ moguls هي يقولون سكينج، أكوام الثلج على طرف الطريق، هاي موجلز. السكينج يسحب ينزل، هاي الصعدات هاي موجلز. فهو يقول لك الكيرفز on the border of the heart. This means moguls. No, normal moguls. Normal pattern, let's say.
But he is talking about pathological of this.
لا يعني الموجل the aortic knob is a mogul, then the pulmonary window is a mogul. Okay, these are the normal. And when it's abnormal, what happens?
First, aortic knob. A prominent knob is a clue to ectasia, aneurysm, or hypertension. Notching or figure 3 sign suggests correctation, as this shown in this picture, with a prominent of ascending aorta is prominent, and notching of rib. In this case of correction of aorta. Second mogul is the main pulmonary artery segment. Excessive convexity is seen with post-stenotic dilatation, as we can see here. Chronic obstructive pulmonary disease, pulmonary artery hypertension, left to right shunt, and pericardial defect. Severe concavity seen in right to left shunts. Third mogul is prominent of left atrial appendage. That's seen in 90% of cases, indicate prior rheumatic carditis. It's not usually seen with other cause of left atrial enlargement. Fourth mogul is bulge above cardiophrenic angle, seen with infarction of ventricular aneurysm. Here we can see this ventricular aneurysm. Fifth bulge is cardiophrenic angle, is caused by pericardial cyst, prominent fat pad, or adenopathy. This is pericardial fat pad. Chamber enlargement. First, we have left atrial enlargement. Is best confirmed by measuring the distance from the mid-inferior border of left main stem bronchus to the right lateral border of left atrial density. This distance is less than 7 cm in 90% of normal patients. If it's more than 7 cm, this indicates left atrial enlargement. And also we have double density sign. Less sensitive sign of left atrial enlargement include splaying of the carinal angle, uplifting of left main stem bronchus, prominent of left atrial appendage, displays the descending aorta to the left. Massive left atrial enlargement can result in left atria become the border on the right side, so-called atrial escape. On lateral view, the enlarged left atrium will displace the bronchus posteriorly, with the bronchus creating right and left leg of the walking man sign. Right atrial enlargement. It's less common than left atrial enlargement. Prominent left atrial bulge is too far to the right of the spine, more than 5.5 cm from midline, or if you have elongation of right atrial convexity exceeding 50% of mediastinal or cardiovascular shadow. Left ventricular enlargement, described it before, elongated left heart border with the apex pointing downward. Prominent and rounding inferior left heart border is also seen. On lateral view, showing enlarged left ventricle extending behind esophagus, that's called a Hoffmann-Richler sign. When left ventricle extend more than 1.8 cm posterior to the posterior border of inferior vena cava at the level 2 cm cephalad to intersection of left ventricle and inferior vena cava. Right ventricular enlargement, it's difficult to diagnose, but we have some clue. If the heart is enlarged and Richler sign does not show left ventricular enlargement, or if you have right ventricle fills too much of retrosternal clear space or climbs more than 1/3 of sternal length, or if you have enlargement of pulmonary outflow tract or hilar arteries. Abnormal mediastinal contour. First, aorta. Dilatation of ascending aorta as a result of postnatal dilatation is seen in 80% of patients with aortic stenosis. Ascending aortic aneurysm can be calcified with syphilis, not calcified with Marfan syndrome. Here we have aneurysm of ascending aorta, this anterior wall, this posterior wall, it's calcified in case of syphilis. Azygous vein, dilatation more than 6 cm in upright PA, 6 millimeter in upright PA, or more than 1 cm on supine radiograph is seen with intravascular volume expansion, elevated central venous pressure, and right heart failure. We can see it in pregnancy or renal failure. Cardiac calcification. Coronary calcification radiograph commonly demonstrate coronary artery calcification in a 3 cm triangular along the upper left heart border, so-called coronary artery calcification triangle. If the chest, as we can see here, this coronary artery calcification, if the chest pain and coronary calcification are present, there is 94% chance that the patient will have occlusive coronary artery disease at angiography. Heavier and more extensive calcification correlate with more severe coronary disease. Detection of coronary calcification helps to differentiate patients with ischemic from those non-ischemic cardiomyopathy. Valvular calcification. First, we should know about the location of this valve on PA and lateral view. As we can see on PA view, pulmonary valve is more superior to the left one. Here we have aortic valve, mitral tricuspid. On lateral view, as we can see, aortic is anterior to mitral valve. Aortic valve calcification is highly suggestive of valve disease. Calcified aortic stenosis is most often degenerative or atherosclerotic in origin and is usually seen in older male. Mitral valve calcification is highly suggestive aromatic valvular disease and is seen in chest radiograph in approximately 40% of patients with mitral stenosis. And is seen much more if it's associated their stenosis and regurgitation together. Only 10% associated with atherosclerotic changes. The shape of calcification is either ovoid or C-shape or J-shape. Sinus of valsalva aneurysm calcification. Here we have sylvinear. This is seen as sylvinear density anterior and lateral to ascending aorta. This is sinus of valsalva aneurysm, but it's not calcified in this picture. Calcified ligamentum arteriosus is seen as linear calcification in the aortopulmonary window connecting left pulmonary artery to the floor of aortic arch. Calcified left atrium. Thin silverlinear calcification in the wall of left atrium is usually associated with mitral stenosis, left atrial enlargement, atrial fibrillation, and left atrial thrombus. Calcified pericardium is typically anterior and inferior in location. It can be single or double layer, associated with high incidence of constrictive pericardial hemodynamic, causes viral hemorrhagic TB pericarditis or post-surgical scarring. Calcified ventricular aneurysm. Thin silverlinear calcification, anterolateral linear apex is most often seen with true aneurysm, or posterior silverlinear calcification is seen in pseudoaneurysm. Here we have posterior, so it's pseudoaneurysm. Calcified infarct. Trophic calcification may occur in myocardial wall from prior myocardial infarction. Calcified thrombus is seen as clumpy calcification in left atrium or less commonly in the left ventricle. Calcified pulmonary arteries. Thin egg-shaped calcification in the wall of pulmonary arteries is virtually diagnostic of a long-standing pulmonary arterial hypertension. Tumor. Rounds or stippled calcification are seen occasionally in atrial myxoma and rarely in other cardiac neoplasm. Here we have myxoma in left atrium and it's calcified in the wall. Pulmonary vascularity. Pulmonary arteries increase circulation from left to right shunt result in enlargement of main and hilar pulmonary arteries with increased blood flow to upper and lower lobes. Asymmetry blood flow can be seen with pulmonary hypoplasia, Seward-Jones syndrome, and congenital lesions such as pulmonary stenosis that's increased to left lung, or tetralogy of Fallot that's increased to right lung. This case of tetralogy of Fallot, decreased vascularity to left lung and increased to the right lung. Bronchial arteries. Tetralogy of Fallot and pseudotrancus arteriosus result in a shift to bronchial circulation. Bronchial arteries are also important in Rasmussen aneurysm from TB and systemic hypervascularity of any chronic infection. Here we can see bronchial artery aneurysm, also an angiography, a case of pulmonary TB. Pulmonary arterial hypertension result in dilated main pulmonary artery, right side cardiac enlargement, central enlargement of left and right pulmonary arteries, pruning of peripheral pulmonary arteries, decreased peripheral pulmonary circulation, calcified of central pulmonary arteries, and enlargement of azygous vein. Pulmonary aneurysm and peripheral pulmonary stenosis can cause unusual enlargement of pulmonary arteries and may be seen in Williams syndrome, Marfan syndrome, and collagen disorder. This is pulmonary artery aneurysm. Pulmonary venous hypertension. The chest radiograph show normally the caliber of vessels are larger in lower lobe than in upper lobe by 3 to 2 ratio. If we have pulmonary venous hypertension, there will be reverse, increased caliber of upper lobe. Cephalization of blood flow is earliest radiographic change of congestive heart failure and pulmonary venous hypertension. Also, we have hilar filling, that's called Viking-Hellman sign. It's caused by enlargement of superior pulmonary vein here, that's located between upper lobe artery and interlobar artery. Pulmonary edema, interstitial edema with curly ABC lines, and also we have thickened fissure. Here we can see curly lines. Alveolar edema begin at 25 to 30 mm mercury wedge pressure. That's seen as a bat wing. Signs of progressive cardiac failure. First we have cephalization, then interstitial edema, then alveolar edema, and finally hemosiderosis and pulmonary ossification. congestive heart failure, radiographic findings include cardiomegaly, left ventricular and left atrial enlargement, cephalization of blood flow, azygous vein and superior vena cava distension, perivascular coughing, peribronchial coughing, curly lines, thickened fissure, subpleural edema, pleural effusion, and alveolar edema. Right heart failure, elevated right side pressure cause right ventricular hypertrophy and dilatation, systemic venous dilatation involving azygous vein, superior vena cava, and jugular veins, tricuspid valve incompetence. Pericardium. About pericardium, is composed of two layers, visceral and parietal layer. Normally we can see it contains 20 ml of fluid. If it's 15 ml, it's abnormal, but 50. Yes, 50. It's abnormal, but radiologically we can detect if it is 200 ml. A pericardial strip exceed 2 to 3 ml is indicative of pericardial thickening or effusion. The differential density sign refers to loosened margin along the left heart border on the PA radiograph or along posterior cardiac border on the lateral radiograph. Large pericardial effusion causes the heart to appear on a frontal radiograph in the shape of a sac of water sitting in a tabletop, as we saw it before. Pneumopericardium appears on plain film as radiolucency surrounding the heart and separating from lung by thin white line of pericardium. Situs inversus means that the patient's entire anatomic arrangement is reversed in a right to left direction as a mirror image. As we can see here, stomach is present on right side, also heart is on right side, so all organ as an opposite side is associated with 5 to 10% incidence of congenital heart disease.
For the future, when you have X-ray of situs inversus, the first thing you do, you ask the technician, are you sure?
Yes.
They mistake a lot. And the second thing you do is to repeat the image. Okay? Even if he says sure, do it again.
Auscultate heart. Dextrocardia indicates that the heart is in right hemothorax. The apex of the heart lies to the right, with the long axis of the heart directed from left to right. Stomach is in its normal position, just heart. Cartaginal syndrome is a combination of situs inversus, dextrocardia, bronchiectasis, and sinusitis. Dextroposition means that the heart is shifted toward the right hemothorax, associated with hypoplastic right lung and an increased incidence of congenital heart disease, particularly left to right shunts. Dextroversion means the cardiac apex is to right, but stomach and aortic knob remain on the left. Left ventricle remains on the left, but it lies anterior to right ventricle. Normally, right ventricle is more anterior one. If there is dextrocardia associated with polycythemia, it's called bilateral left-sidedness. As we can see, both lung contain two lobes. Also, we have bilateral superior vena cava and congenital heart disease, especially atrial septal defect. If we have no spleen, with no spleen, acyclinia, and dextrocardia, there will be bilateral right-sidedness. Each lung contains 3 lobes, and it's more severe one than the left one. Hypersegmentation of sternum is present in 90% of patients with Down syndrome. Wavy retrosternal linear opacity suggests dilated internal mammary arteries associated with connotation of aorta. Pectus excavatum associated with mitral valve prolapse. Pectus carinatum associated with VSD. And we have scoliosis with shell chest associated with Marfan syndrome, aortic valve disease, coarctation, aortic dissection. Presence of 11 or fewer rib associated with Down syndrome and atrioventricular canal. Reborn rib or bifurcated rib, and if it is associated with overcirculation, suggests truncal arteriosis. if associated with under-circulation, suggests tetralogy of Fallot. Rib notching and inferior rib sclerosis indicate collateral circulation, as we can see in correctation of the aorta, especially 3rd through 8th ribs. If you have fracture of first or second rib, indicate high velocity blunt trauma. Nuclear radiography. Normal perfusions can appear in a shape of horseshoe in the vertical or long axis, or a donut in short axis. Hypoperfused segment on stress image which fill in the rest indicate of ischemia. Hypoperfused segment on both rest and stress image are usually infarct or scar. Echocardiography. The thickness and motion of the myocardium can be evaluated throughout the cardiac cycle. Pericardial effusion are shown as echo-free space adjacent to myocardium. The most posterior chamber we have left atrium, and posterior to it we have aortic valve. Anterior to aortic valve we have right ventricle. This is a tricuspid valve, mitral valve.
This is transesophageal.
Yes.
So the left atrium is the posterior.
Yes.
The upper part is the posterior part
Yes.
of the image.
This is interventricular septum that's appear as an echo, and thickness 10 to 11 mm, same as the left ventricular wall. Normally, interventricular septum it's thickened and moved toward left ventricular when during systole. Paradoxical septal movement may be seen in pericardial effusion, cardiac tamponade, chronic obstructive pulmonary disease, asthma, ASD, and other disease. Coronary anatomy. The right coronary artery arises.
You should know something about it. At least you should know. Well, how does it look? I don't. لا ممكن ينفع السيارة وأنا مش as numbers, no.
It's difficult.
Yeah, it's for cardiologists mainly, not for radiologists.
Right coronary artery arises from right coronary cusp, and the left coronary artery arises from left coronary cusp. Approximately 85% of patients are right dominant, meaning that the right coronary artery supplies the posterior descending artery and posterior inferior surface of myocardium. Here we have left coronary artery. Its branch, left anterior descending artery. It is runs anterior in the interventricular septum and gives branch, septal branch and diagonal branch. And other second branch is circumflex artery that's run in anterior lateral portion and give obtuse marginal arteries. And sometimes had third branch which is called ramus intermedius. Right coronary artery pass anterior and to right between pulmonary artery and right atrium. Its branch, first branch is conus branch. It's due to pulmonary trunk. Then we have a branch to SA node, and we have acute marginal branch, and lastly posterior descending artery. That goes to posterior and inferior surface of the heart. Coronary pathology. Fixed coronary stenosis. A 75% reduction in cross-section area is required to cause significant reduction in blood flow. That's equal to 50% reduction in Other significant findings include coronary calcification, ulcerative plaque, and aneurysmal formation. Here we have stenosis.
You have diameter stenosis and area stenosis.
Yes.
So 75% reduction in the area stenosis is the same as 50%
in
diameter.
Diameter, yes.
Okay. That's a sheep.
Catheter-induced spasm is most often seen in the right coronary artery as a smooth transient narrowing 1 to 2 mm distal to catheter tip. The patient usually remain asymptomatic. Transmittal variant angina is angina secondary to prolonged coronary spasm. Kawasaki syndrome is an inflammatory condition of coronary arteries, probably attributable to prior viral syndrome, which result in coronary stenosis and aneurysm. Occasionally persists into adulthood. We can see stenosis, aneurysm in angiography and here as well. Myocardial bridging describes a normal variant in which coronary arteries penetrate and then emerge from myocardium rather than running along surface of epicardium. Cardiac angiography. Angiography of the heart in adult most often involve left side catheterization via arterial puncture with retrograde examination of aorta, left ventricle and left atrium. Selective catheterization of coronary arteries is also accomplished from arterial side. Wall motion is evaluated globally and regionally. We have hypokinesia that describes diminished contractile or less systolic motion than normal. Akinesia means no systolic wall motion. Dyskinesia is paradoxical wall motion during systole. Tardikinesia refers delayed contractility. Asynchrony refers to cardiac motion that's out of phase with the remainder of myocardium. Ventricular aneurysm appear as a bulge in the wall that's moved paradoxically compared with other area of left ventricle. This is during diastole. This is during systole. When it's contract, there will be appear here as a bulge. In the apex, that means true aneurysm. Cardiac CT is important for evaluation of dissection of aorta and pulmonary artery thrombi and many abnormal anomalies. Coronary artery calcium screening. Chest X-ray has sensitivity of 42% and fluoroscopy has sensitivity of 40 to 75% and specificity of 52 to 95 of detection of coronary calcification as indicator of coronary stenosis. Coronary calcification is a significant marker of underlying atherosclerosis. We have a Gaston's method where coronary calcification is defined as an area of greater than 130 household unit and larger than 2 millimeter square. A score of 1 is given for 130 to 200 household unit. Score of 2 is given 201 to 299 household unit. 3 for 300 to 399 household unit, and 4 for more than 400 household unit.
This is called calcium scoring.
Yes.
Nowadays, it's very important indicator of stenosis, especially on the cardiac CT. طبعا هذا ما نسوي يعني هو سوفت وير يعني.
صعبة.
لا it's not that difficult. It's software بالcardiac CT algorithm. بس it detects areas of the surface area of the calcification and the density. And but you just point it out, and the CT will show you score of calcium score is 1000. So you report it. يعني مو بعد شو نحسبها سكوير مليمتر تو density احنا ما نحسبها الكمبيوتر يحسبها. اوكي يعني هي مو صعبه هي بس بالكمبيوتر سوفت وير.
We will multiply these to the according location in the coronary artery. Then we sum it together. We will have a score. If it's a score from 0 to 10 is very low, too low risk. 11 to 100 moderate. 101 to 400 is moderately high. And greater than 400 is high risk for underlying stenosis and further cardiac events. Cardiac MRI. Cardiac MRI application includes congenital heart disease, aortic and pulmonary artery disease, pericardial disease, ventricular function, valvular function, cardiomyopathy, and cardiac masses. Cardiac pacemaker are considered contraindication, but most prosthetic valve are safely studied.
يمكن هاي أهم أكثر جملة مفيدة بكل البرزنتيشن بالنسبة لنا. البالون not contraindication. الستنت not contraindication. الفالف prosthetic valve not contraindication. يعني مو كل ما اجى واحد عنده ستنت ها لا خلاص كانسل. عادي. اي وهذا غلط احنا نسوي. We We have to make it right.
ترى I think even يعني حتى اكو بيس ميكر هسه compatible
وهسه نزل
يعني
pacemaker
حتى ماكو
بس
شيء
MRI compatible.
يعني كونترا انديكيتد.
على ايش؟ اذا ماكو بيس ميكر نو بيس ميكر نو بس حاليا بس بيس ميكر. حتى ستيرنوتومي ستيل وايرز نوت كونترا.
The best anatomic depiction is accomplished by spin echo T1 weighted image, in which the moving blood products produce a signal void or black blood appearance. This short axis view, this right ventricle appear as triangular in shape, while left ventricle round, and this is interventricular septa. In spin echo, the blood is appear black. Cardiac echo or fast field echo image imparts bright signal to coherently flowing blood, creating white blood appearance similar to contrast study. This is during diastole. This is during systole. As we can see, during diastole, the ventricles are larger in size, while in diastole are smaller but thick wall and thick interventricular septum. Steady state free precession. This is a type of gradient echo that are flow independent. So in the cardial border detection is significantly enhanced, produces excellent spatial and temporal resolution and high signal to noise ratio and relatively short breath holding time. This is a 4-chamber view. We have abnormality here. This is during diastole. This is during systole. As we mentioned, the wall will be thicker during systole, while here in anterior wall it's the same. That means this area is abnormal.
It's not
Part.
fact.
Yes. Myocardial tagging. Place virtual marker within heart through manipulation of magnetic field to facilitate visualization and quantification of regional function, including rotational and translation motion that has been previously difficult to analyze. That's we can see if there is deformation during different cardiac cycle.
بالريلاكسيشن يحطون جريد على المايوكارديوم. طبعا الجريد هو ماجنتيك فيلد جريد مو جريد حقيقي. من يصير كونتراكشن الجريد راح ينجعص ويل تخيل حاط جريد على مصر وده خلصنا راح شو يصير بيها؟ راح تتعبى لورا.
Deformation.
اوكي؟ فالاreas that does not deform they are abnormal. اوكي؟ ملخص كل اللي وصلنا فيه.
Coronary magnetic resonant arteriography compensation for cardiac and coronary arterial motion is achieved by using short acquisition time and optimization timing and acquisition of mid-diastole when cardiac motion is least. Respiratory motion correction can be achieved by several different techniques. This be coronary artery.
Coronary MRI until
يعني ما على بعد ما
not commercially used. This is for research purposes only.
MRI also is important for evaluating congenital heart disease, as we in this case we have ASD and muscular type of VSD. Also in tetralogy of Fallot, which characterized by right ventricular hypertrophy, VSD overriding of aorta, and pulmonary or vestibular right ventricular stenosis. This imaging of cardiac MRI, 4-chamber view, short axis.
Yes, sign MRI. Like a cinema. And by the way, you can do it in the whole machine.
Thank you.
Wallah, thank you. Really thank you. Viking helmet sign. Viking helmet sign.